So just a quick recap from 2 weeks ago. So I talked about two broad categories of economic evaluation. The first being in practice, where we're undertaking economic evaluation to inform local priority issues. And secondly, in research, where we're maybe not addressing issues that are of specific priority to local health services in the current time, but we're generating evidence on new service delivery models, for example, that provide value and that we think may be fundable in the future. And we talked about analysing from a health system and health service perspective. And we talked about options for improving service delivery. We talked about investing to generate additional benefits. So we're interested in whether the additional costs are justified by the benefits, whether we're investing up front to reduce costs downstream, potentially looking at stopping models that we're currently providing where the costs are not justified by additional benefits. And then I've added in a fourth category in honour of Rob and the continuous improvement program here at Flinders, where we can also improve service delivery through quality improvement methods. And here we're essentially trying to do more with the same. So we're trying to reorganise the resources that are currently being used to improve outcomes in that manner. And the reason I bring that up is because there's well-established frameworks for quality improvement, continuous improvement, that we've kind of used as a basis for thinking about how we could use economic evaluation in a local health service setting. So here's the SALIN continuous improvement framework. And you see steps 1 to 4 are around identifying problems, understanding those problems in the current service delivery context. 5 and 6 are around designing solutions, designing interventions, and then 7 and 8 are around evaluating the impact of implemented changes to the delivery of healthcare. And so we've kind of taken those three broad phases, and thought about, well, how could we use economic evaluation to address issues around designing and implementing new service delivery models. And so first phase we talk about is problem definition, priority setting. There's limited capacity in terms of using economic evaluation, so we need to use that capacity wisely. Secondly is the solution design phase. And then thirdly, the evaluation of implemented solutions. And so the next 3 weeks we'll get into this in a bit more detail, but today I just wanted to give a brief overview and it'd be great to get people's thoughts and feedback on those ideas, which will inform what I talk about in the next 3 seminars. So thinking about problem identification, kind of distinguished, so I'd say that this idea of early and iterative economic evaluation is relevant for both economic evaluation in research and in practice. And so in a research setting, we think about how we might identify problems. They could be informed by the availability of technologies and how we might use those technologies, or it might be, we might say, more bottom up in terms of identifying unmet need and looking at how we can address those unmet needs. And then in a practice setting, I'm proposing that the problem identification may be more driven by measures of performance and trying to improve performance of local health services. So just some examples of how we might apply those different approaches to identifying problems. So in a technology section, we've got horizon scanning methods. So these are some examples that actually have been recently or are currently being implemented in SAL. And so Derek Chu led a large clinical trial where he'd identified high sensitivity troponin testing as a new technology that could improve the management of people presenting at the ED with chest pain. Bogda has been looking at the use of digital platforms to collect patient-reported outcomes to improve, to identify and improve management of cancer patients' supportive care needs. In relation to unmet need, this can be either data-driven. So a good example here, again, with Bogda, is the data has shown that cancer patients are at increased risk of cardiovascular disease. And so taking that as a starting point, Bogda's been thinking about models of care, service delivery models to address this increased cardiovascular risk in cancer patients. And practice-driven, so just from looking at issues that arise through the delivery of healthcare here, again at Saarland, Dr. Anand Rose has identified this issue of, in the respiratory section, they're identifying incidentally detected pulmonary nodules through their imaging data. And initially they were getting these and they didn't know how to manage them, so they've developed a virtual multidisciplinary team approach to managing these incidentally detected nodules. So a range of examples of how problems can be identified that could be solved through the delivery of services in a different manner. From a performance perspective, so in practice, how we might identify areas in which we want to use economic evaluation to support improved performance, we may look at areas in which the health service is incurring financial penalties. So currently, there are penalties incurred around hospital-acquired complications, but that in the future may broaden out to include readmissions and other events. We may just be interested in how can we increase capacity, whether that's through reducing length of stay, reducing admissions or readmissions, or reducing ED presentations. All could contribute to increasing capacity of the health service. Or taking Rob's example, we could look at specific clinical areas where the health service is essentially losing money. Their costs are greater than the revenue that they're receiving. And so we can look at specific diagnostic-related groups to try and work out whether new service delivery models can improve performance or whether quality improvement is enough. So maybe you'd start with quality improvement. If we can't generate the improvements we're after through quality improvement, then you maybe move to an economic evaluation approach. So with that as background, I just wanted to talk about the ideas that our health economics group at Flinders University have been thinking about. And this is a commentary that myself and my colleague Andrew published earlier this year, where Andrew came up with this idea of participatory economic modelling. So economic modelling or decision analytic modelling is a common framework for economic evaluation of health technologies. And so we were thinking, well, how can we apply that framework in a local health service setting? And so the idea is that we're using, and I'll show some examples in a minute, some decision analytic model structures to work with stakeholders in the health service, whether that's clinicians or managers, consumers, to foster a common understanding of the problem that's being addressed and the potential solutions and the likelihood of the costs and benefits associated with those solutions. So we're talking about representing the possibilities in terms of what's possible in terms of improving the service delivery, the probabilities in terms of the likelihood of different outcomes associated with different potential solutions. And Andrew was quite clear on this issue that we're not answering distinct yes and no questions or decisions. It's more along the lines of not yet. So we may be looking at a potential solution and we get to a point where we make a decision, but the decision isn't no, we're just going to throw it in the bin. Yes, we're going to implement it. Is maybe we need to work on this a bit more. We need to understand the potential costs and benefits of this intervention before we implement it. So it's a not yet. Or there's a yes, but yes, we'll implement it in certain circumstances, look at how it's going. So it's building on that continuous improvement framework, but using economic principles and methods to support that process. So our proposal is that you start as early as possible, so early and iterative. So at the early stages, it's going to be quick and dirty because you haven't got that much data available, but it can still potentially, and these are all things that need to be tested, inform the prioritization of areas in which you want to work further and collect more data to inform the value of potential interventions. So an example I'm going to use to illustrate these concepts is around hospital-acquired complications. And so if we think right at the start of that process where we're thinking, right, we want to address hospital-acquired complications, what data do we have? We have some data. So we've got data that can be accessed quite easily on capacity to inform the capacity for improvement. So we've got data on the number of different types of hacks that are occurring. We've got data on the financial penalties that we're incurring. We've got data on comparative performance, so we know how we're doing, or one health service is doing compared to all other health services. We've got a traffic light system. And we also can get, without too much effort, information on preventative processes that are currently in place in our local health service, and maybe look at things that are happening in other health services as well. And then ideally at this stage we'd also maybe take a brief look at the literature to get some idea of the potential interventions or the evidence on potential interventions that could be put in place to inform our ideas or estimates around the likelihood and also the cost of improvement. And so if we think about how we might represent that data, and this is a very crude decision analytic model, but we're basically at the top there, we've got current practice, and we may have looked at what we're doing in a particular area. So here we're looking at hypoglycemic hospital-acquired complications. So we may say, well, actually, we're not doing anything specifically at the current time to address this issue of hypoglycemia in the hospital. We can describe the number of hacks that are occurring, and we can have data on that by the risk of the cohort. So how the hospital pricing authority do it is they categorize the hacks in terms of whether a person who experienced the hack was at low risk, moderate risk, or high risk of experiencing a hack. So we've got that information. And so in this case, hypothetically, we may observe that we're performing poorly relative to other hospitals. And then we can see the financial penalties. And so just using the data that we've got initially, we can make some quick and dirty estimates of what we think the potential and likelihood of improvement might be in terms of what might be the type of intervention, whether it's a pharmacist-led intervention. What's our first quick and dirty estimates of the likelihood of reducing hacks in these different categories, the flow-on effects to financial penalties, as well as thinking about improvements in patient outcomes. I mean, that's ultimately what we're interested in, and what the purpose of the financial penalties is to provide an incentive to improve care, as well as potentially saving bed days. So we can populate this type of model, which would inform a first prioritization question. So we've done our early economic evaluation. The decision is, do we prioritize hypoglycemic hacks to take forward to designing interventions, or do we prioritize some other area in which we think there'll be more value from using our scarce economic resources? Then we get to the next stage, which is the intervention design stage. And so here we've got a bit more time. We can collect some more data. So we can use administrative data, describing, generating some more information on the types of patients in our local health service who are experiencing these hacks. We may decide that the administrative data only takes us so far, that we may want to undertake a clinical audit to extract more detailed information on the types of patients experiencing these hacks, which will inform what types of interventions we expect to have the greatest effect. And so here we can undertake what's called an intervention synthesis, which I'll briefly introduce in a minute, and update our economic modelling and keep going through this iterative process until we get to a point where we think, right, we're ready to make that yes but decision rather than a not yet decision. So just as a hypothetical example, we may do a clinical audit and identify the types of patients who are within the low risk category, within the moderate risk category, and the high risk category. So you can see here moving from medical patients receiving non-insulin based diabetic medications through to ICU patients who are receiving enteral feeding. And then we can look at the evidence review. So we do a more formal review of the evidence to identify evidence on the effectiveness of interventions, service delivery models that have been used to prevent or reduce hypoglycemia in hospitals. But then we got the question of how do we interpret that evidence in the local context. So you see here I've just described some of the variation that you're always going to see when you're reviewing published evidence. There's going to be variation in the types of interventions. So there may be a range of pharmacist-led interventions, for example, and the next slide will show that. But they're never going to be exactly the same. Well, almost never going to be exactly the same. So how do you interpret that variation? Variation in the context in which the study was undertaken, population characteristics, the comparator, so what was local practice, and of course variation in study quality. So all of these factors need to be taken into consideration when you're interpreting the evidence to generate estimates of your expected effects of these interventions. And so my proposal, or our proposal, is that this idea of intervention synthesis is a useful method that can be used to interpret evidence in a local context. So this paper here, published in, I think it was 2014, provides a really nice overview of the methodology. But essentially, you look at the evidence as a whole and you make a decision about how you're going to interpret and synthesize that evidence. So it may be that you review the evidence and you say, there's one study that's head and shoulders above all the others. We're going to use that as our basis to inform our potential intervention. Going all the way down to intervention component analysis, where you essentially unpick the interventions that have been evaluated and you're trying to work out which components of a service delivery model are having the effect, and then put the components that are having an effect together. And you can do that either manually or you can do that statistically. So this is just an example of how this data is put together for that type of synthesis. So this is a synthesis of evidence on electronic medical records in a pediatric setting. So you can see we've got a range of studies, we've got the country, we've got whether it's pediatric specific, and you've got the components of the electronic medical records, and you can see how there's variation in terms of which components are included in which studies. And so that's your starting point, but then you obviously got to spend time understanding or trying to understand which components are having the greatest effects. In the hypoglycemic example, we've undertaken a review, and I think we've identified 55 papers that report potentially relevant evidence on service delivery models to reduce hypoglycemic hacks. But just to illustrate the kind of issues that we're coming across, these are just the studies that reported on pharmacist-led approaches. So you can see the first two are reasonably similar. So the pharmacist is working with other clinicians to develop the insulin orders and coordinating perioperative management, including discharge. So they're both relatively similar, but then you've got the third model, which is a more intensive model. So it's a diabetes management team involving pharmacists, nurses, and dietitians doing daily rounds of diabetes patients within hospitals. So clearly there's you would think, a cost difference in those different interventions, but then it's trying to estimate the difference in effects, and we can then put that into the model to estimate the costs and effects of these two options as a starting point. So having been through this process of perhaps clinical audit, perhaps intervention synthesis, we can update the model. So again, Here we've got a much better idea of what we believe the intervention to be, or one of the potential interventions to be, so we can assign costs more accurately. And the idea of the intervention synthesis is actually to, in combination with the local data, with the administrative data or the clinical audit data, we can generate estimates of the effectiveness in terms of the actual numbers of hacks that will be prevented and the health gains associated with those, as well as the bed days, and then that leads into estimates of the impact on financial penalties. And so, very simple example, and obviously there's a lot of steps involved in getting to this point, but it hopefully just illustrates the kind of process we have in mind, and that we're actually part way through this process with the hypoglycemic hacks here at Saarland. So iterative, but the question that or the decision that we'd be aiming to inform is whether to implement a proposed intervention, a service delivery model to reduce hypoglycemic hacks. And so we got not yet, in which case we maybe continue to refine the intervention, update the model until we get to a point where we're ready for a yes but, and we implement and evaluate the intervention. Which takes us to the final phase of the iterative process, which is the economic evaluation of implemented interventions. I'm not going to say too much about that today, because that's kind of the more established use of economic evaluation. You know, we design a study to collect data on costs and outcomes, and we do our economic evaluation. We again can update our economic model using the data from the implemented study. So there's a range of issues around study design, perspective that you're going to take, the outcomes that you're going to collect during the evaluation. And so you may think in terms of a gold standard study design may involve multi-site, so multiple sites involved in the evaluation, a pragmatic randomized study that reflects how the intervention would be used in practice. You take a societal perspective, so you're capturing the broadest range of costs, and you can do sub-analyses to look at different perspectives, and you collect patient-reported outcome measures so that you can estimate QALYs, but you can also look at operational outcomes. Compared to maybe a minimum standard where a single site, observational study design, but ensuring that you're collecting appropriate data and analysing that data appropriately. You may only take a single perspective because you're limiting your data collection, and you may only look at operational outcomes. So we'll discuss these issues around study design in the 5th seminar when we come back to this issue. So in summary, what we're proposing is this process of early and iterative economic evaluation that builds on quality improvement processes that have been developed here in Saarland and more broadly across the health system. We've got these 3 phases of problem identification, priority setting, solution design, solution implementation, and evaluation. And the final point I want to make is that part of our objective is not to just do this here at Saarland, but is to develop shared resources or common resources that can be used across different local health services. So in our hypoglycemic example, we're developing an economic model, we're doing audits, we're doing an intervention synthesis. A lot of that information can be used and save time if other health services want to do similar things. So my ideal world would be we'd all be doing this across Australia, but we'd be coordinating. So that we're looking at hypoglycemic hacks, Narland's looking at UTIs, someone else is looking at, and then we can share those resources to inform the greater use of economic analysis across local health services. So that's my plan, and that's just provided a kind of summary of how we think economic evaluation could be used in a local health service context.
Okay, thank Thanks, John. Excellent again. I'm going to open up for questions. I've got one from Slido, but while you're thinking of some questions, I want to just explore a few things with you. And I'm glad you talked about hypoglycemia because, as you know, as an intensive care doctor, we've been involved in a lot of studies with blood glucose control in critically ill patients with variable results on all of that at the moment. So I guess when we're talking about maybe doing an evaluation that has a broader context across other areas, some of this might depend on what the local practice is compared to the practice everywhere else. So in this organisation, I know our endocrinology team have, and I've been a little bit involved with that peripherally, have done a bit of work looking at the control of blood glucose compared to the HbA1c, so the long-term glucose control measures with that, which might not be done in another hospital. So and then as part of that, I think things might change. So we're about to have this electronic medical record. Now, the usual way for glucose control in hospital these days is using what's called a basal bolus method. So you have a long-term 24 hours or longer injection and then some corrective injections on top of that. We do that with a paper method, but my understanding is that our electronic medical record is not has not been able to be adapted in other sites to use the basal bolus. So we will probably lose that. That'll probably lead to some problems with our glucose control. So how do we have to reassess that when we go to the electronic medical record? So in the iterative process, is this something that keeps going each time you have a change?
Well, it's interesting you raise that because we're working with a working group here at Saarland, and so we're kind of working with them to review the local data, so what's happening locally, but also the evidence. And they were, right from the start, they were aware of this issue, that currently there's no electronic medical records, but they are coming. So we're kind of going down a twin track of kind of saying, well, what could we do now? What might be useful to do now, whilst we haven't got, but with an eye on the fact that electronic medical records are coming. So yeah. So it's having that knowledge from working with stakeholders is, if we were just doing this in our ivory towers, we wouldn't know that.
Yeah.
So,
Rob.
So this may be a bit clumsy, but you've got an economic analysis where there's real money, so hacks where there are fines, and avoiding fines has an absolute direct impact on the bottom line. Then other improvements that bring about improvements in length of stay, extremely important, but paradoxically can have a negative economic impact. So how do you handle that in the equation?
well, so that's what I'm saying about undertake the economic evaluation from different perspectives. So if I was undertaking the economic evaluation from a Saarland perspective, then it would essentially be focusing on the financial penalties as the cost impact, because as we discussed and as you showed, that the funding does not mirror the costs. So that would be my proposal, would be to undertake it from different perspectives with a view to showing the impact of those different perspectives, but from a local decision-making perspective, then yeah, I mean, if from a local decision-making perspective you're showing that it's not cost-effective, then what decision do you make? Because your example, Rob, where you showed that despite the perverse incentives of the funding mechanism, you continued to do the right thing clinically. The right thing clinically may be to implement a service delivery model that is not the right thing from a financial perspective. So it's, yeah, what do you do?
So that sort of feeds into a question from Slido, which I think is typical of some people's views of these things, is that if something goes wrong, it's not the financial analysis that gets looked at, not the financial analysis that goes to the coroner's court. It's what's best practice. And so people are going to argue, what's best practice? I don't care about the financial implications. It's what's best practice. Okay.
I mean, so economists actually like to talk about reputational costs.
Mm-hmm.
And so I guess that would come into it, wouldn't it? Because especially with hacks, you're being compared and you get your red or your yellow or your green tick. So I guess if you're in the red and your comparative performance is poor, then maybe you put a value on those reputational costs. I don't have an answer to that.
No. Well, I guess I know,
Thoughts?
and I think we could go for a while here because yes, the organisation will put a value on their reputational costs. The individual may not. So now you have how do we work as a team and how do we work as individuals. We're going to have to wrap up.
Yeah.
Pressure on the area, but thank you, John. Thank you, Rob. Fantastic session again. We meet again in 2 weeks to take it a step further.
Yeah.
Thanks everybody for your participation, and thanks everybody online. A few more Slidos next time would be excellent. Bye then.